Welcome to the update session by Academy of Consultation-Liaison Psychiatry 2025. In this session, we will be talking about incretin receptor agonist, popularly known as GLP-1 and GIP medication, and their relevance in psychiatric landscape. I am Kamalika Roy. I'm an associate professor at Oregon Health and Science University in Portland, Oregon. I have Dr. Mason Allen with me. He's an assistant professor at OHSU along with me. In this session, we will be discussing about incretin receptor agonist, and I wanted to clarify that we do not have anything to disclose or no conflict to report in relevance to this presentation within the last 24 months prior to this declaration. The session will be divided into two sections. The first section will discuss the indications, mechanisms, and psychiatric relevance of these medications. In the second section, I will discuss about the safety and available data about this medication. Over to you, Dr. Allen.
Okay. Hello, everyone. So as Dr. Roy said, we'll be discussing indications, mechanism, and the efficacy of these medications. So to start out, the FDA-approved indications for these medications, the incretin receptor agonists, type 2 diabetes, treatment of type 2 diabetes, treatment of obesity or overweight with a comorbidity, overweight with moderate to severe obstructive sleep apnea, a reduction of serious cardiac events and stroke in patients with cardiovascular disease who are obese or overweight, to improve cardiovascular death and worsening kidney function in patients with type 2 diabetes who also have CKD or chronic kidney disease, and then to help improve metabolic dysfunction associated steatohepatitis or MASH in adults with moderate to advanced liver fibrosis. Next, this slide deals with the mechanism of action of the incretins, the incretin medications, specifically here pictured as GLP-1. So broadly, it mimics the endogenous GLP-1, which is present in the gut and brain. It works to improve glucose-stimulated insulin release, improves satiety via the hypothalamus, and decrease gastric emptying or delay gastric emptying. More specifically, you can imagine it kind of broadly affects these 5 organ systems. So with the liver, like we said before, it decreases hepatic steatosis, decreases lipid content. In the brain, it works to improve satiety, decrease appetite, and therefore decrease food intake. It increases insulin secretion in the pancreas. In muscles and body, decreases insulin resistance, increases energy consumption, and improves lipolysis. And finally, in the gut, as we said before, decreased gastric emptying, decreased GI motility. So finally, beginning to kind of look at the indications and like the relevance of the GLP-1 medication specifically in psychiatry. So these are kind of conceptualized, or we conceptualize them in 3 domains. We can think about it as benefits where the psychiatric patients are more vulnerable, their use in treatment of iatrogenically caused obesity, and their potential for the therapeutic effects in psychiatric conditions themselves. So as a reminder, incretin receptor agonists have not been approved by the FDA for any psychiatric condition. So thinking about that first domain, the vulnerability and comorbidities that our patients experience, so they are at increased risk of obesity compared to the general population. They have an increased prevalence and risk of cardiometabolic complications, my apologies, an increased risk of PCOS, an increased risk of steatohepatitis, and an increased risk of obstructive sleep apnea. Iatrogenically, antipsychotic-induced weight gain is a huge problem, as we all know. These medications can cause massive gains in weight and the sequelae of cardiometabolic problems. And then finally, we begin to look at the therapeutic or preventative action that these medications might have, with possible impact on mood symptoms, possible impact on cognition, and really importantly, their possible impact on alcohol use and cravings and substance use disorders in general. So, beginning to look at the medication and the data that's been gathered on psychiatric populations, we kind of look at three areas. So the first one, the first study that we look at was titled Psychiatric Safety of Semaglutide for Weight Management in People Without Known Major Psychopathology. This was a post hoc analysis of the STEP 1, 2, 3, and 5 trials. So in this trial, in this study, the semaglutide 2.4 milligrams, which is the standard dose, was given weekly in overweight and obese patients and was compared to a placebo group. They looked at it from baseline to 68 weeks. And what they noted was, one, it was safe in these patients, and how they determined that was the semaglutide group was less likely to progress to a higher PHQ-9 score. So to put it more succinctly, the patients who were given semaglutide were found to be less likely to increase their depressive symptoms. Looking at the next study, this was looking at psychotropic drug-associated weight gain, and it was titled The Effect of Liraglutide Treatment on Prediabetes and Overweight Patients on clozapine or olanzapine. So they looked at these patients for 16 weeks, and they noted the liraglutide group had significantly more people who reached standard glucose tolerance and had weight reduction. Finally, looking at substance use, these are reviewing sort of three trials. So the first one was a systematic review of exenatide and duraglutide, which showed significant decrease in alcohol and nicotine use in patients who were given these medications. That was a little bit older data. The newer data, looking at semaglutide, which is a much newer medication, also showed significant reductions in alcohol use, weekly consumption, and cravings associated with alcohol. So finally, looking at the semaglutide and schizophrenia, this is a brand new trial, and by brand new, I mean it was published on September 3rd, 2025 in JAMA Psychiatry, and it was titled Semaglutide Treatment of Antipsychotic Treated Patients with Schizophrenia, Prediabetes, and Obesity. It was a randomized controlled study. So in this patient population, they were given semaglutide 1 milligram weekly in patients with schizophrenia who are being treated with a second-generation antipsychotic and who also have prediabetes and obesity, compared to a placebo group looking at it up to 30 weeks. The results were pretty remarkable, I'd say. So the semaglutide group reduced hemoglobin A1 scores to less than 5.7% in 81% of the study group, compared to just 19% in the placebo group. So the semaglutide group had a significant body weight reduction compared to the placebo. The semaglutide group had significant improvements in physical quality of life, and the semaglutide group did not negatively impact psychotic symptom scores as measured by the PNSS-6. So the relevance of this is semaglutide at a lower dose, and I wanted to note that semaglutide 1 milligram is lower than the standard dose of 2.4 milligrams as mentioned in the prior studies. And this was effective in improving glucose tolerance, body weight, and improving physical quality of life without affecting their psychiatric symptoms in patients with schizophrenia who are being treated with antipsychotics. Again, very new data and very promising data.
Thank you, Dr. Allen. It's interesting to see that in the last study in the schizophrenia population with prediabetes, they actually used a lower dose of semaglutide, and that also showed significant benefit. Just to clarify, the medication is used at a lower dose when treating diabetes, and it is used at a higher dose when treating obesity. These people had obesity or pre-diabetes, but they decided to choose the lower dose of medication in that randomized controlled trial. Okay, so transitioning to the section 2 of this session, talking about the safety concerns about this medication. So these medications have been in market since 2005, so it's been 20 years. But between 2020 and 2023, there was a 600% increase in prescription of GLP-1 medications, especially in women. That might have something to do with the significant media attention these medications get, and also the influencers' attention this medication has drawn. And these medications are also widely available as non-formulary preparations through compounding pharmacies, which is starting to kind of roll back nowadays due to regulations. However, this widespread expansion of these prescriptions and also availability of this medication brought into attention many different side effects, and one of them was the concern about suicidality. There are drug safety reporting system in every country, and for an example, in 2023, there were reporting of new onset depression and suicidality to the Icelandic Medicines Agency. That led to investigations by the European Medicines Agency and the UK Medicines and Healthcare Products Regulatory Agency. And those investigations found some association between suicidality and these medications. However, causation could not be determined because it was just a drug safety reporting system, not a study. Later came the pharmacovigilance studies, which are usually done in large databases. For example, FDA's Adverse Event Reporting System, European Medicine Agency's EUDRA Vigilance System, World Health Organization's WIGI-BEST system, and the Australian Database of Adverse Event Notification System. These studies looked into the concern of suicidality and these medications. Their data was actually mixed in both directions. So some of these studies found some association between suicidality and specifically semaglutide and liraglutide, but some of the studies also found a negative association, that means reduction in suicidality with this medication. Interestingly, when they tried to do the analysis, including the time to onset of the event and concomitant medication use, they did not find any association between suicidality and these medications. Pharmacovigilance studies are not the best in determining causality between an exposure and an event, because these studies are not necessarily interpretable or generalizable to a large population because of the methodologic limitations that does not actually help us to directly observe the data and infer causality. The study designs that are usually used to infer causality are observational studies. We will talk a little bit more about causality and association towards the end of this session. However, there were many observational studies that came through the last several years looking into the concern of suicidality and GLP-1 medications. Many of these studies actually compared GLP-1 medications with other anti-diabetic medications to look into their comparison of suicidality. Overall, there was no association between GLP-1 medications and suicidality. Some of these studies actually found some reduction in some aspects of suicidality when looking at it using this medication. Currently, FDA recommends that we closely monitor for mood changes, emerging or worsening of depression and suicidal behavior. Last year, European Medicine Agency Safety Committee concluded that the available evidence did not support any causal association between these medications and suicidal behavior. As we are talking about safety concerns and these medications, we need to also see what is plausible. That is one of the area which helps us to inform causality. So it's important to mention reward deficiency syndrome, which is thought to be impaired in substance use disorder, and dopamine dysregulation, of course. GLP-1 medications are known to help with reward deficiency syndrome, but they also promote a hypodopaminergic environment in certain areas of brain. By no means they're anti-dopaminergic, but they modulate and create a homeostatic dopaminergic regulation in certain areas of brain. And probably that's how it helps with cravings for substances, as Dr. Allen just mentioned, shown in the study. So theoretically, a hypodopaminergic state can lead to anhedonia. And we all know that anhedonia is a depression phenotype, and that can lead to suicidality. However, the relationship between anhedonia and suicidality is not very well studied. There are studies that looked into whether anhedonia leads to suicidality. Unfortunately, those studies did not necessarily consistently use the anhedonia measuring scales. However, even if we think that anhedonia and suicidality are causally related, the fact is GLP-1 medications in preclinical and clinical studies did not show any negative impact on the hedonic state. So even if we consider hypothetically these medications can cause some suicidality, there is no plausible explanation of the mechanism of how that would happen. Here, I would like to mention 3 different studies with 3 different designs, actually. The first one is an observational design cohort study that looked into 2 different groups. One group had obesity, other group had type 2 diabetes mellitus. And while looking into these 2 groups, they divided these groups into 2 different cohorts. One got semaglutide, and the other in the obesity group got anti-obesity medications. And some of these anti-obesity medications were psychotropic, like bupropion, naltrexone, or topiramate, or phentermine, and so on. In the type 2 diabetes mellitus group, they compared between semaglutide and non-GLP-1 anti-diabetic medication. In both groups, the primary outcome they looked into was suicidal ideation, first or recurrent suicidal ideation at 6 months. And in the type 2 diabetes group, they expanded the observation to 1, 2, and 3 years. In the obesity group, GLP-1 cohort had significantly lower risk of recurrent suicidal ideation. In type 2 diabetes group, GLP-1 cohort had significant lower risk of incident suicidal ideation. And here also I'd like to mention there was a greater reduction in suicidal ideation in the obesity group, which used a higher dose of semaglutide, as I was mentioning in the last study mentioned by Dr. Allen, which was done in schizophrenia. In this group also, the risk reduction for suicidal ideation was greater in the obesity group, where they essentially used a higher dose of GLP-1 medication, semaglutide, indicating there might be a possible dose-response relationship with reduction of suicidal ideation and semaglutide. So it's a little bit opposite to what initially was reported to the adverse drug reporting system. The second study I would like to mention is a systematic review and meta-analysis of randomized clinical trials. They included 27 RCTs that was studying GLP-1 medications for 6 months or more. In total, they included some 32,000 individuals receiving GLP-1 medications and 27% receiving placebo. This study population included diabetes and obesity. And the primary outcome was suicidal ideation, self-harm, attempted suicide, or completed suicide. In the GLP-1 group, that number was 0.047 per 100 person years. And the placebo group, that number was 0.042 per 100 person years. And the difference was not statistically significant. These studies included in the systematic review were mostly homogeneous. Only 5 studies were found to have a risk of bias, and due to their 5% attrition rate in follow-up, which was pretty low attrition rate compared to other studies. This study is relevant because it again underscores that it is unlikely to have an increase in suicide-related adverse event in GLP-1 receptor agonist group. The last study I would like to mention is a unique design case time control study, which is a variation of case control design where cases are actually used as their own control, comparing an event before and after an exposure. What it does is it limits the confounding factors, confounding variables to a great extent. This study was a nationwide case time control study done in a French database. They included almost 1,100 cases and 5,500 controls. In that sample, more than 2/3 actually had a recent psychiatric history, and more than half of this population had obesity. Here, the primary outcome was, of course, suicide and suicide attempts, and it was found that the GLP-1 receptor agonist group was not associated with an increased risk of suicide or suicide attempt. This design controlled for many different variables, including insomnia, depression, anxiety, substance use, social isolation, and family history of suicide. They also did a bias analysis, and to reduce the bias, they included this anti-diabetic group of medication, which is called dipeptidyl peptidase inhibitors, which is also an incretin mimetic drug. And the examples are sitagliptin, vildagliptin, and saxagliptin. They used those medications as the placebo or the control. This study is again relevant because it complements the existing abundance of literature that shows that there is no specific risk of suicidality in patients who have psychiatric history and obesity. So generally, how to analyze the data on safety? Generally speaking, suicidality comprises of many different things, including suicidal ideation, behavior, completed suicide, and so on. But the adverse drug reporting system, when they reported suicidality, they did not further explain the disparate aspects of suicidality. And the studies, including the observational studies that looked into suicidality and these medications, they did not consistently use the valid scales like Columbia Suicide Rating Scales. We also have to remember that type 2 diabetes mellitus and obesity have a higher risk of psychiatric disorders, and this population can have increased risk of suicidality to begin with. And another aspect is that obesity and metabolic dysfunction like polycystic ovary syndrome are associated with suicide, and some studies actually implicate that this association between obesity and metabolic dysfunction might be independent of the co-occurrence of mental disorders. So the population that we are studying might be at a higher risk of suicidality to begin with, the population that are using GLP-1 medications. So there are a lot of gaps in the existing data. The components of suicidality need to be characterized and measured better with valid scales. There needs to, the observation that we have about the positive association between suicidality and GLP-1 medication actually lacks consistency and plausibility. Here I would like to mention Bradford Hill criteria, which was basically proposed by Bradford Hill, epidemiologist, back in 1965. This criteria comprises of 9 viewpoints, and those are strength, consistency, temporality, specificity, biological gradient, plausibility, coherence, experiment, and analogy. Not that every criteria has to fulfill to infer causality, but we need to remember that causality is actually inferred entity. It's not instantiated or it's not defined by any means. We infer causality depending on what we observe in the data, in the epidemiological data. So this Bradford Hill criteria was instrumental. It provided a framework for concluding that tobacco consumption was not only associated with cancer, but also causally linked with lung cancer. So when we try to implement the same criteria here in the available data, we have specifically the data that suggests that suicidality can be associated with GLP-1 medication. That observation literally lacks in consistency and plausibility at this point. And as earlier I mentioned, impact of these medications on the hedonic state needs to be further systematically studied. So there are several gaps, and we can actually explore more systematically research into this topic. However, I would like to have like a bottom line take home points from this presentation. We know what we know by preponderance of evidence is these medications, it has significant impact on obesity and metabolic dysfunction, which are very much associated with psychiatric disorders. These medications have significant impact in improving cardiometabolic events, which are the most important and most common cause of premature death in psychiatric disorders. These medications are known to help with psychotropic-related weight gain. They are also promising in terms of reducing cravings in substance use disorder. There is some preliminary data, as mentioned by Dr. Allen in that post hoc analysis of another study, that implies that this medication might even have some positive impact on mood. So these are all preponderance of evidence. But what we don't have is there is no evidence that there is a causal link between suicidality and GLP-1 medications. In fact, there is reproducible evidence that this medication might even help, might even have some positive impact in at least some aspects of suicidality. Knowing about these medications and feeling proficient as a psychiatrist is important, because we can collaborate with other physicians when our patients are on these medications, or we can even advocate for our patients to consider these medications and discuss this medication with their primary care physicians or endocrinologists, as these medications are known to help with quite a bit of medical things that are relevant to psychiatry, like cardiometabolic events or medication-induced weight gain. And as a psychiatrist, we can also consider getting further training and certification to be able to prescribe these medications and have further knowledge and further scope of practice. Here are our references. These are the citations we used for this session. And this is all about incretin receptor agonists and their relevance in psychiatry. Thank you for attending this session.